Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative for the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of March 29th, and as I record today, March 30th, happy Doctor's Day for those of you listening who are doctors. We have globally 127.8 million cases with almost 8 million deaths reported in the world. In the United States, 30.3 million cases with 550,109 deaths. In kids specifically, as of the AAP report from March 25th, we have 3.4 million total cases, which is 13.4% of the total number for the United States. That comes out to just over 4,500 cases per 100,000 pediatric population. Here in Arizona, we remain at the number 6 position in cumulative numbers of cases, with a total of 134,243 cases since the start of the pandemic. That comes out to just over 16% of our total number of cases for Arizona, and a rate of 7,300 per 100,000 pediatric patients. Again, that's birth through age 17. We are at 26 deaths, which are COVID-19 related. That is second only to Texas in the United States, which has 48 deaths. So the numbers, of course, are continuing to increase. I think we're all quite aware that we've had both good news and bad news. Good news in that Arizona has now opened up vaccination from age 16 and up at all the state-run point of distribution sites, the pods. That's great. That's fantastic. Unfortunately, Arizona also has followed the lead of other states in the country by rescinding what remained of its mask mandates unless local communities, so far Tucson and Flagstaff, choose to keep them in place. So I think we all can anticipate, as Dr. Fauci and also leadership at the CDC have stated, another surge as states around the country back off from the social distancing and the mask requirements too early. I think we're all quite aware that there are emerging variants out there. And in fact, this is the subject of the first excellent question which has been submitted to this podcast. And this is, what is the effect of vaccination on the spread of variants and why? It's kind of a difficult concept because you would think A equals B, of course, but what about the why? So here is my understanding of the current science behind this. As with influenza, a viral burden, or what's called viral load, of over a certain amount allows for natural selection or natural emergence of a variant virus. How does that happen? Well, as it turns out, all viruses and actually all life, which has DNA or RNA as its point of origin, undergoes spontaneous point mutations. These just happen. It's sort of basically a little chemical change in one amino acid, and boom, you've got a single point mutation, most of which are not significant. However, if point mutations occur within an important gene, for example, with the SARS coronavirus 2, within the spike protein gene, and there are several, and if that point mutation creates a conformational change in the structure of the protein, then you can get clinical significance in how that virus attaches to its target cells in the respiratory epithelium, and potentially, therefore, how virulent it might be. That's in the spike protein. Other mutations can occur in other elements of the viral machinery, allowing it to perhaps replicate more readily, to bind more strongly, to eclipse the machinery of its target cell much more rapidly or effectively, thus precipitating death of that respiratory epithelial cell or wherever the virus binds. So that's how mutations occur. And they are going to occur regardless of how many viruses are out there. What we're really talking about then is a statistical probability of getting that one mutation which is clinically significant to allow a new variant to emerge, which might have potential to escape from the protection from vaccines. Larger numbers of viruses, more spontaneous mutation events occurring, higher probability of a successful mutation occurring. It's that simple. So what happens with vaccination? All we're hoping to accomplish with a rapid vaccination of everybody in the world is to reduce the number of people who are walking around with or exposed to or at risk for developing high viral load themselves. Anybody who is infected is going to have a much higher viral load, therefore higher viral numbers with risk of successful point mutations than somebody who is not infected at all or at the very worst exposed, maybe colonized, but not infected, developing disease. So the vaccine efforts that are all recommended to reduce the risk of viral mutations are simply trying to reduce the overall circulating viral load and reduce that probability of a successful event occurring. Great, fantastic, wonderful. Even with that, keep in mind that all of the mutations so far described have been relatively limited in the structure of the spike protein. Yes, in some instances, for example, the United Kingdom's B117 and the California, the Cal20C, and even the South African variant, those mutations in the spike protein have allowed for an increase in infectivity, up to actually 50% for the United Kingdom's and the California strain, both of which unfortunately are quite present and robust in Arizona, unfortunately. So that takes care of the increased infectivity, but yet the vaccines currently available, which we are administering in Arizona, remain highly effective, or I should say effective, sufficiently against those variants. Great, fantastic, wonderful. The concern then is that if you have a lot of people unvaccinated running around with high viral loads of both of those viruses in Arizona, that serves as a beautiful mixing pot, similar to the bird flu, for the two viruses to combine, such as they have already in Los Angeles, and created a small cluster of cases of a combined hypervirulent, hyperinfectious strain. That's the event which everyone is hoping to avoid, because such a combination event, or what's called an antigenic shift event, is going to be dangerous, highly dangerous. We just don't want to run the probabilistic chance of that occurring again here in Arizona. So that is the science behind that, such as it is. And of course, screening for, looking for, and examining the impact of these variant events is a major focus around the world. And the United States, thankfully, is finally catching up. In the UK, they've been doing this since almost day one of the global pandemic. We are finally getting there ourselves. Okay. Next question then has to do, and this is somewhat related, with the availability for booster vaccinations. What are they? What should we get them? Should we recommend them, etc., and so forth? The booster vaccinations is probably inappropriately named, because they're not actually boosters per se. They're actually modified vaccines to reflect the emerging variants. So, for example, both Pfizer and Moderna, the makers of the two messenger RNA vaccines out there, have submitted what are being called booster vaccines to the FDA for assessment. They're not really boosters at all, but they're modified to include the messenger RNA from the South African variant, for example, or the United Kingdom variant. So they're sort of additional vaccines to boost our immunity against all of the virus and virus variants out there. So none of those are currently available. They're all under testing. They're undergoing clinical testing to look for efficacy and, of course, to confirm safety, etc. Should those boosters be approved and then released, at this point, I think it might be premature to recommend boost vaccinating everybody. Certainly high-risk individuals, those who are immunodeficient, those who are of older age, those with comorbidities at risk for severe disease, of course, I think would be first in line. But we have yet to do a fuller, better job of vaccinating everybody else. And even though Arizona has opened up vaccination to age 16 and up, we still have a whole bunch of our pediatric population who are not yet able to get vaccinated, and even availability is not going to get every single 16 years old and up vaccinated in Arizona. Brief update on the pediatric vaccine trials. Moderna is recruiting for from 6 months of age and up for its messenger RNA vaccine. The recruitment site is in Phoenix. There are 2 studies ongoing. One is an initial, very rapid 650 patients to look for safety and tolerability. The second one is part of a national trial, 6,500 children ages 6 months of age and up, to look for efficacy, antibody protection, and of course the safety. So that recruitment is ongoing. I have personal knowledge of several study participants who have been recruited into that study, the children, who are scheduled for a May uptake date. So we're looking into the spring and certainly early summer, I think, before we might even anticipate initial results. The hope, of course, is that we may have vaccine approval for 6 months of age and up before or concurrent with the start of the next school year, so 21-22. Fingers crossed for that. What about the concept of vaccination passports? This is not new. Certainly from the early days of the global pandemic, there was a consideration of proven immunity either from wild-type infection or by vaccination once they're available to allow travel. Those are certainly being posited in Europe as a point of requirement for entry into a country in Europe. The United States is similarly considering those to allow travel, but international travel as of this stage. I have not seen discussions yet about domestic travel within the United States. However, it makes sense that some degree of proof of immunity is going to become standard as we start to open up society. Obviously, it's happening, I think, personally, too quickly right now. But at some point in time, and that this will factor into one of the other questions, before we can successfully consider the pandemic over, we'll need to have proof of immunity, either from vaccine and or from wild-type disease, in at least 70-75% of the population. Ideally, it would be 85% and higher to really assure herd immunity. And vaccination passports is one way to establish that number. Just to formalize the process of recruiting or getting uptake for the number of successfully protected individuals. So I do think that USA will implement immunity passports or vaccination passports, but the timing, of course, is way out there, and no predictions on when that might be. So to that next question, what metrics are used to determine when the pandemic is officially over, and who declares that? Great question. Don't know the answer to that. I think, unfortunately, the current metrics that we're aware of are all being used to establish when is it safe to come out from behind our masks. When is it safe to send the students back to schools? And of course, in most parts of the country, and certainly in Arizona, that has already occurred. So the metrics of less than 10% infection rate is one possibility. Other metrics used by the Arizona Department of Health Services is use of ICU beds and ventilators in the state, hospitalization rates, that sort of thing. None of those, of course, accurately capture the risk of yet another surge, unfortunately. Just because we have open hospital beds means nothing about the fact that the virus itself is over. So I think we'll end up seeing, in terms of declaring the pandemic over, several reporting periods, longer than a week, but I would say several reporting periods of at least a month each, of decreased numbers below a certain cutoff, likely below 1% infectivity rate, and no current global outbreaks elsewhere. That number is a long ways off, and I think even the most optimistic estimates will put the date of declaring the pandemic over minimum a year from now. Even with vaccinations, even if we're successful in vaccinating, even if the world is lucky enough not to see emergence of a hyper-virulent mutant which escapes the current interventions, we're still looking at ongoing surges or at least waves of cases, I think, for the next year easily. So we got a long ways to go. Who declares that? Well, the World Health Organization, WHO, is the international body that declares the start of a pandemic, so presumably they will be the ones to convene their scientific advisory body and declare an end to the pandemic. And absolutely zero messaging or rumblings from the WHO about even considering that. So we have a long ways to go. Alrighty, so somewhat similar to that, then another topic. What about in-person groups without either without masks or at least the ability to schedule a small group get-togethers? And the specific question is about scheduling a class reunion, which would likely include non-maskers and non-vaccinated attendees. Yeah, boy, it is unfortunately way too early yet still, and I've been saying this unfortunately for the last year, way too early to figure out when that might be safe because I cannot predict, and I think no one can, what might be the severity of our next surge. Absolutely, there is going to be one, especially as Arizona comes out from behind its masks way too early. I would predict that we'll have another increase in numbers. I hope it won't be anything resembling a surge in terms of medical infrastructure use, but at least increased numbers. So I think it's hard to predict when it might be safe to actively recruit and support gatherings. Now, if those gatherings are outside, and certainly, we're getting closer, as we know, to the summers already hitting the 90s, it won't be so very pleasant to be outside in large or small group gatherings. But that might be a possible way to convene, for example, a reunion or something like that, which would include or under vaccinated people and people in varying stages of mask acceptance. But I'm not going to come out and say that it's safe to do that because there may well be secondary cases related to that. Per the CDC, individuals who are fully vaccinated, and I think we all saw this and I talked about it at the last podcast, fully vaccinated individuals may participate in small group meetings without masks, even if they're meeting with somebody who is not vaccinated but at low risk of either getting disease or low risk of complications. And here we're thinking, of course, of the fully vaccinated grandparents finally getting free license to go visit the grandkids and their kids if those families are at low risk of severe disease. I think that is pertinent to planning small group settings. In the office where I spend most of my time, it's the education office at my community hospital. There are 8 of us who work here, all of us fully vaccinated, and our families also are protected either by vaccination or at low risk. So we are choosing not to wear masks when it's just us. However, we have students, residents, other faculty, people coming in frequently. The masks go right back on until we know their vaccination status. So it's a lot of hand waving. I think there are no definites. I think obviously all of us have the ability to interpret local risk factors when we're trying to plan an event, and it'll have to be with a nod to what is the community spread, what are the current numbers, and just what are the risks of a secondary case. Would that be a bad thing or not? All right. Then the next question: if COVID vaccines become available for distribution in pediatric offices, can they be given together with other vaccines administered? The answer to this so far is no in terms of co-administration. And the reason for that is that the safety of such co-administration has not yet been established. It makes sense, certainly for the messenger RNA vaccines, which are about as inert as you can get, that there would be no negative interactions between those and other vaccinations, including live attenuated virus vaccines such as the measles, mumps, rubella, or the varicella vaccinations. However, that data does not yet exist. So as of the last update from the CDC on March 5th of this year, there is still a recommended 14-day waiting period before or after COVID vaccine to administer other pediatric vaccinations. The one exception to this would be in a high-risk situation, for example, young child vaccinated against COVID-19, we're not there yet obviously, but just theoretically, who then has a tetanus exposure or a rabies exposure. That would be an individual who would need their booster tetanus vaccination or, for example, rabies vaccination sooner than the 14 days. The risks of not providing that vaccination would outweigh any theoretic risks of an interaction or loss of or lack of immunity for providing vaccine within the 14-day window. So for right now, co-administration is not yet approved or suggested. 14 days between the COVID vaccine and the other routine vaccines. In terms of distributing COVID-19 vaccines in pediatric offices, and this is a follow-up to last week or the last podcast, I absolutely, completely and fully support this as the most successful and likely to be efficacious way of administering vaccines, especially to pediatric patients and also to their families for that matter. But in terms of the numbers of vaccine doses available in Arizona and the planning of distribution, I've not heard that is yet being fully supported. So far, vaccines are being administered by state-run sites, county-run sites. Tucson at least finally got permission from the state to pursue FEMA funding to do a national vaccination site. But so far, the messaging is not to support small dose delivery quota in pediatric practices. I 100% support doing that as soon as that is possible. And I think it's reasonable for us as a community of pediatric physicians and healthcare providers to lobby for that from the state. It makes a lot of sense, especially as doses are being released to local pharmacies to be delivered, which is a much more sort of happenstance encounter to get vaccine delivered. So there we go. I think that is the list of the questions for this week. As always, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Meanwhile, hang in there, stay safe, stay sane, stay passionate. Thanks, everybody.